Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. I am thrilled to kick off 2025 with a phenomenal news cycle of video conferences from our Centers of Excellence. Expect this year to bring luminaries through our team of Baptist Health International with the newest and innovative advancements in neuroscience, cardiovascular, oncology, orthopedics, and all related to general surgery. To kick off this year, I have the pleasure of welcoming all of you from Latin America, the Caribbean, our friends in Europe and the Middle East, and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Luis Compres Brugal. His presentation is titled Advancing Our Understanding of Progressive Multiple Sclerosis. Dr. Luis Compres Brugal is a director of Neuroimmunology and Multiple Sclerosis at Baptist Health Miami Neuroscience Institute. He specializes in the treatment of multiple sclerosis and neuroimmunological conditions. Dr. Compres Brugal earned his medical degree with honors from the University of Iberoamericana School of Medicine in Santo Domingo, Dominican Republic. He served as a chief resident during his adult neurology residency at the University of Cincinnati Medical School in Ohio. Following his residency, he completed a fellowship in multiple sclerosis and neuroimmunology at the University of South Florida, which was supported by the National Multiple Sclerosis Society. During his fellowship, he served as a sub-investigator in numerous clinical trials to advance the field of multiple sclerosis and neuroimmune inflammatory conditions. Dr. Compres, you have no idea how thrilled I am to welcome you to this particular presentation and to our team. I know that you have had a few months to absorb everything about Baptist, and this is a new standard for us as well in neuroscience, and we are so thrilled that you as a specialist have joined our team. So thank you so much for accepting our invitation. The floor is yours.
Thank you very much, Dr. Hakim. Thank you for the introduction, and thank you everyone for having me here. Let me share my screen. Okay. All right. I'm assuming you can see Dr. Hakim, right?
Yes, it's perfect.
All right, awesome. All right, well, thank you very much again. My name is Luis Compres Brugal. I am a neurologist here at Baptist, and today we're gonna talk about what is driving progression in patients with multiple sclerosis. These are my disclosures. So objectives for this lecture, we're gonna review the classification of multiple sclerosis, review and understand the MS prodrome and MS spectrum, learn some of the mechanisms driving progression, review some of the data of disability progression, and what are the future directions. Okay. All right, to start off, this is a fake clinical scenario made up by me, but is something that I see almost on a daily basis in patients with MS. So Lucia, she's a 50-year-old woman, and she was diagnosed with multiple sclerosis approximately 25 years ago when she was 25 years old. Her last clinical relapse with new MRI activity happened 15 years ago, and she's been on different disease-modifying therapies since she was diagnosed. She now comes to the clinic for a routine follow-up with a yearly MRI that showed no new lesions in comparison to the prior one. After hearing this good news that her MS is stable, she says, well, doctor, every year you tell me that my MS is stable, but I feel like I've been getting worse over the past few years. I now need a cane to walk around the mall, and I can't walk as long as I used to. My memory is also getting worse, and I can no longer meet deadlines at work. What is happening? And again, this is a very common scenario. For one way or another, I get similar questions like this. Well, a lot of you during medical school, and you know there are different types of MS, and broadly, it's relapsing remitting, secondary progressive MS, and primary progressive MS. For the purpose of this presentation, let's try to forget about this and let's try to look at MS in a different way with a different lens. I'm not saying this is not true, but just bear with me for a few more minutes. Okay. In terms of characterizing MS, our field is moving away from these traditionally based separate clinical stages to a more biologically based understanding of the disease progression. What we know is that MS is a disease spectrum. There are several mechanisms happening at the same time, including acute and diffuse inflammation in the CNS, and there's also neurodegeneration. There's compartmentalized inflammation in the CNS as well. Okay. All right. So the MS spectrum, in terms of prodrome, the MS prodrome is a well-known phenomenon happening in MS. And what we know is that occurs several years before the first clinical attack. And they can present with different symptoms, such as they can be non-specific, fatigue, depression, bladder, bowel problems, pain, fibromyalgia, migraines. These patients also, the number of clinic visits increased before the first clinical attack, and the use of healthcare increases years, even 10 years before the first clinical attack. Many studies have shown also that the use of prescription medicine in comparison to control patients increased a year before the diagnosis. The main point of this, what I want you to learn and know, is that the biology, the disease process of MS is starting way before, years before the first attack. Okay. This is a topographical model of MS from Dr. Krieger. I like it because it can give me an easy way of understanding this spectrum. This is a pool. This is the deepest end of the pool, and this is the shallow area. Here we have the cerebral hemisphere, and this is the spinal cord. The water represents the brain reserve, and this white lesions, these are the MS lesions. So when one of those plaques or lesions go above the water, that's the clinical threshold to have symptoms. Before I go to this, let me show you this video. And what we're about to see is progression over approximately like 15, 20 years. What is happening in a patient with MS? They keep accumulating lesions, but also the brain reserves start going down. And let me just play this. So as you see, patients are having accumulating lesions. A few of those go above the water, above the clinical threshold. The brain reserves are slowly going down over the years. And once you get to this stage, all these old lesions, they start causing problems. And that's what we are calling secondary progressive MS. Let's go back to this. Here at the bottom, we have radiological isolated syndrome. It's pretty much when you have MS lesions, but you haven't had any clinical attack. Then you go up and develop the first clinical attack, and we call it clinical isolated syndrome. Then the next one, you have another one, and radiological isolated syndrome. Relapsing remitting MS. And then after that, once the brain reserve goes down, you keep having this progression of all lesions and call it progressive MS. Okay. What do we know about disability progression, and what is driving this slow progression over time? And can our current DMT prevent this? This is an old way of thinking of what was driving disability progression. That is not completely wrong, but it's not the only one. Pretty much MS is starting in the periphery. Activated lymphocytes, they go to the CNS, causing acute focal inflammatory lesions with gadolinium-enhancing lesions, a relapse, they go to the hospital, they get steroids, some of them recover, but others, they have what we call relapse-associated worsening, or RAW, pretty much incomplete recovery. And what we knew, or what we thought, is that that was the only thing driving progression, as they keep accumulating lesions, relapses, and more worsening. But that is not the only thing. Let's review some of the data about DMTs and disability progressions in MS. This is the OPERA trial with the ocrelizumab. Ocrelizumab is one of our highest efficacy therapy. What they were looking at is that here, most of the disease progression occurred independent of relapse activity, or PIRA, meaning the vast majority of patients in this line here, they progress without new MRI activity and without new relapses. There were a few that had relapses and they progressed, but that wasn't the majority, and not by far. What this is telling us is that even with a high efficacy therapy, there is something else going on that is making these patients get worse over time. This is another trial looking at patients with relapsing remitting MS over 15 years. The total population was almost 15,000, and 1,000 of those were followed for more than 50 years. And what we are seeing here, these treated patients in red and the untreated, is that they both progressed. They both had disability accumulation, to a lesser degree, those with that were treated. But still, it's the same story. Even if we are treating with high efficacy therapy or with therapy, there are some patients that progress. And let's look at this other one, looking at patients that only take modifying therapy that progress in secondary progressive MS. What they saw is that approximately 20% of the patients in years, while being treated with DMTs, they convert to secondary progressive. And it's a similar story. Even they're treated, those with high efficacy therapy with natalizumab, alemtuzumab, or moderate efficacy therapy like fingolimod, they still progress to a lesser degree than those on a low efficacy therapy like lactimera acetate or interferons. Again, so with these studies, I think I have give you a picture of there is something we are not addressing with our current DMTs. There is disability. There is a process that we might be overlooking. So what is it? Well, why? Why is that happening? This term called smoldering MS, which some are now calling, this is the real MS. Pretty much what it is an umbrella term that is characterizing chronic pathobiological processes in the central nervous system that is associated with neurodegeneration. It starts very early on in the disease courses, even in the preclinical phase. So even before a patient goes on and develop a new attack or the first attack, there is some evidence of progression in these patients. And it continues across the spectrum. All right. So this is a very busy slide, and I don't want to bore you with all the details. But what I want you to learn is that there are many different things happening. It's just not the relapses, but there are many different factors, including lifestyle, lack of exercise, smoking, diet. Those are very significant contributors to progression in patients with MS. There is chronic infections. There's aging mechanisms, pathologic aging mechanisms in MS. There's chronic activation of the immune system, mitochondrial dysfunction, and microglia activation, which is one of the most important one, and one that is being a big area of research and therapeutic target. All right, so let's, in a very simplified way, look at a brain of a patient with MS. There are many different things happening at the same time. we first, up here, we have the peripheral initiated MS lesions or MS attack here with gadolinium enhancement. We have axonal destruction. At the same time, we have other lesions that are remyelinating or trying to recover. We have, and we're going to talk a little bit more about the iron rim or paramagnetic rim lesions, which are chronic activated lesions. We're going to talk about that in the next several slides. Here, this is something that when I first learned about that, I don't know, it stuck with me, because even when we are looking at the brain MRI, we saw those lesions and we used to think that those are the only places that have pathology, but no, there is diffuse white matter inflammation in patients with MS, even though if we don't see it on our conventional MRIs, but you can see it in this PET scan. There is subpial and cortical lesions causing demyelination and inflammation. And we have chronic meningeal inflammation as well up here. So all these different processes are combining and happening in every patient with MS. Okay. All right. To briefly mention and talk about microglia, pretty much what it's supposed to do is a regulatory cell, innate immune system, is supposed to balance the homeostasis of the brain, but for whatever reason, it turns into a pro-inflammatory state. And here at the bottom, these cartoons, we have the normal microglia, then in the pre-active lesion, involved in the acute MS lesion, and then it is one of the main components in slowly expanding lesion that we're going to talk about next. Okay. What are chronic active lesions? Pretty much are demyelinated MS lesions that are resulting from the progressive accumulation of neuronal tissue damage and axonal loss. And there are two main types of chronic active lesion. We have the slowly expanding lesion, which are inactive plaques with continuous demyelination at the edge of the lesion. So over months, years, they slowly get bigger. That we don't see it as frequently or as easy on our MRIs that we're getting in our clinic to monitor these patients with MS. We can, but of course, it's more with more sophisticated images for research purposes. But what we do know is this is a real thing and happening in a lot of patients with MS. Another type of chronic active lesion is the paramagnetic rim lesion or PEARL. These are characterized by an iron-laden pathogenic microglia. So it's similar, but these microglia are accumulating iron, which is more neurotoxic. And they have a higher degree of tissue injury. Let's look at this MRI here. This is the PEARL with iron around it. And we can see that on our normal MRI, 3 Tesla MRI, even 1.5 Tesla MRI, we can see them. And it has a lot of clinical utility, not only now with the new diagnostic criteria of multiple sclerosis that was presented a few months ago, this is included. This is something that I look in every patient with MS. Whenever I get an MRI, try to diagnose. If I see the presence of a PEARL, that helps me make a more accurate diagnosis. If I have a patient with MS, I look for PEARLs because they have a prognostic value. The more they have, those patients, they might not do as good. And let's look at this PET scan on a patient with 40s with relapsing remitting that has had MS for 12 years now. As you can see, these are inactive or not acute lesions. What this is telling us is that the microglia here is very active. Even though the patient might not even have new symptoms, But again, it's going back to what I was mentioning before. There is ongoing inflammation that we are not seeing. Okay. So why do we care about these chronic active lesions? And a lot. Just looking at this study for almost 200 patients, almost half of them, they had one or more chronic active lesion, and having that, it was predictive of brain atrophy. And 22% of patients, they had 4 or more chronic active lesions, and that was even predictive of cognitive and motor disability at an earlier age. So you can see here in this graph. So yeah, that is important. Like I also was mentioning, detecting pearls is a little bit easier than the slowly expanding one. As you can see here in this picture, this is a conventional MRI. You can make a case that I hope you can see it. This is a baseline MRI, and this is an MRI 12 months after. There is a little bit bigger. The lesion is a little bit bigger. Same thing here on the T1. So this is a slowly expanding lesion that even in 12 months progressed. Up to 40% of plaques, MX plaques or lesions, they show some sign of chronic activity, and they are present throughout the disease course, including in the clinical isolated syndrome or the radiological isolated syndrome. They are way more apparent in the progressive disease. 90% of MS patients will develop at least one slowly expanding lesion. So that one is more common than the pearls. That is approximately 50% of the patients, they have one or more pearls. What about lymphoid aggregates? Lymphoid aggregates are meningeal pockets of lymphocytes causing active cortical demyelination. And that's one of the main drivers of PIRA, or progressive of independence of relapse activity. They are highly associated with cognitive problems and motor problems, and again, these pockets of lymphocytes, they are present even before the first attack. I believe that now with this information, we can make an argument that yes, this part of MS is really important, trying to prevent acute focal relapses, new lesions from forming. But what is driving inflammation is way more complex than that. It is a combination of both. We have the peripheral initiated inflammation that we are doing a great job now with all of our current therapies that we have come up with, trying to prevent all these lesions. And but I'm not gonna say we have been neglecting, because this is ongoing, very active and ongoing research trying to understand this smoldering MS, which is mainly driven by compartmentalized inflammation. So when we have this combination, in addition to other factors such as comorbidity, age, brain health, and lifestyle socioeconomic factors, that is what causing inflammation. We have to look at the whole picture, and that's where the primary care involvement in patients with MS is really, really important. Because yes, as a neurologist, I can control new inflammation, I can come up with new therapies, but keeping the patient healthy, keeping the water from the pool from going down is one of the most important things as well. Trying to control their diabetes, trying to control their high blood pressure, making sure they are not smoking, aggressive physical therapy, aggressive exercise. Those are really important factors. This is another graph to solidify the point that the biological onset of MS starts way before the clinical onset, and it continues throughout the lifetime, pretty much. And that relapse-associated worsening is active. usually the several years, several decades after the diagnosis. But at the end, when patients are getting in their 60s, 70s, 50s, what is the main driver of progression is the smoldering MS. Where are we going from here? Now that we've done an amazing job, great job at controlling new relapses, we need to do a little bit better at preventing the progression. So this is where new therapeutic targets such as Bruton tyrosine kinase inhibitors or BTKIs, they have an important role because they are directly impacting how the microglia is talking to the other cells. And very recently, the FDA approved the first BTKI, tolebrutinib, which is the first drug approved for secondary progressive MS without activity. And it has shown to not only slow down the progression, but to improve. And this is a very big step in our field. And it's from here on, it's just going to get better. And there are other BTKIs are in the market, and there are other class of medicines besides that, the one that we have right now that is under investigation. A lot of remyelinating therapies as well. There's a lot of ongoing research in trying to recover or target how the myelin is going to function back. How we measure disability in clinical trials, there's been a lot of discussion of moving from the traditional way of how we are measuring disability to more sensitive ones and ones that would have a more clinical impact. And we are going in the right direction. And we need to include patients with greater disabilities in our trials. Usually, patients that are already, let's say, wheelchair bound are just excluded from these trials. And those are the patients that sometimes need our help the most. But again, we are moving in the right direction. Just to summarize, we are moving from this traditional based definition of MS to a more biological based understanding. The pathobiology of MS starts way before the first clinical attack, and it progressed throughout the disease course. Progression of disability can occur independent of relapse activity. And there are many different mechanisms of actions. And by understanding those, we can come up with new therapeutic targets. Targeting microglia is a potential therapeutic target, as was explaining with the Bruton tyrosine kinase, and controlling the comorbidities and adopting a healthy lifestyle are definitely essential to delay the progression and help these patients. All right, thank you very much. These are my references.
Thank you so much, Dr. Brugal. I love that you focused only on the challenges of multiple sclerosis, because obviously, despite the fact that we don't receive a great number of patients on a daily basis, the fact of the matter is that these patients are the ones who require the assistance of the multidisciplinary teams as soon as it's identified. Some things to actually highlight that strike a chord, and it's the fact that these patients start developing the condition years before the initial manifestation, or as you call them, the initial attack. And it could be up to 15 to 20 years, which is absolutely a remarkable thing if you were to think about it retrospectively when we encounter these patients with multiple sclerosis. And the initial shock for those patients that you guys care for, that manifest the bulk of the symptoms, such as fatigue, those kind of pains, incontinence, bladder or bowel, the cognitive declines, those are clumped in the initial attack of the patient. So in my mind, and I'm sure in our peers that are not even close to neurology, might think is, my goodness, how do we approach these patients? How do we help them? How do we help them transition and navigate in order for you to initiate some of the treatments that we currently have?
Yeah, that's definitely a good question. And in terms of, do you mean like selecting the disease modifying therapy or the specific MS therapy? Yeah, look at everything. Now, what we are trying to do is hit them hard at first with a high efficacy therapy. Before, many years ago, the concept was a step therapy. Try with a low efficacy therapy, safe therapy, and if they have a relapse, well, then we keep escalating. But no, now what I try to do is, and what we all try to do is use the high efficacy therapy, try to balance the comorbidities, make sure that they would be with a disimmunosuppressant, that they won't have increased infections, for example. If there is a patient with that has recurrent infections, they have a lot of comorbidities, I might lean away from one of those that are going to suppress immune system more. And at the end, it's a conversation with the patient, trying to figure out what they're going to adhere to. We have oral therapies, we have injections, we have infusions. There are patients that say, no, I'm going to forget to take a pill every day. And those are, okay, well, then an injection it is, a monthly injection it is, or a weekly, or a infusion every 6 months. There are many different factors from patient preference, evaluating the effectiveness and the comorbidities.
Mm. And you're absolutely right. I mean, there are so many things that you're juggling at the same time,
Mm-hmm.
and in the mind of the patient and the caregiver is even more so. Obviously, you're already understanding what you're going to do as a physician, but putting ourselves in the place of the patient, it might be somewhat of a challenge as well. Especially
Yeah.
because it affects also not only the cognitive decline that eventually will ensue, but more the mental stability of the patient. Simply put, the diagnosis is a tough one. And I guess some
Yeah.
patients will suffer from any kind of relapse in the mental state as well, like depression, or have you seen that in your patients?
Yeah, depression is and mental illnesses is as all this ongoing inflammation that brings mood disorders as high of the comorbidities or the
Yeah.
symptoms from MS. So yes.
Um, Ligia is saying, thank you for the excellent presentation. What is the life expectancy of the patients with multiple sclerosis?
Yeah, now patients are expected to live a full life. They do have, based on more recent studies, like a little bit decreased life expectancy. But what I educate my patients is that I expect them to live a full life. We can just treat them, and I don't have a reason that MS by itself are going to kill you. Now, if they have very advanced disease, have had MS for many, many, many years or decades, they're probably going to be very disabled. They're going to be prone for more infections, immobility, and those problems are going to lead to hospitalization and morbidity and mortality.
I have a comment and a question from Dr. Diego Paz in Honduras. It says, thanks for the lecture. Has there been any studies with dietary modifications or cold and heat exposure type therapies, such as plunge and saunas, as an effective adjuvant type therapy for these patients?
Yeah, good question. So first, for the diet, what we do know and what I educate my patients is to avoid ultra processed food. That is one of those lifestyle changes that are directly related to disease progression. That would be the main thing. Avoid just junk food. Um, yeah, there's no specific diet that has shown a greater evidence than others in terms of helping with the progression or relapses. the Mediterranean diet, it has good evidence, even intermittent fasting, but nothing super concrete. The main thing that I focus on is avoid ultra-processed food. Try to eat healthy, wide variety of food, and cope that with exercise. In terms of the heat and cold therapy, there's this well-known phenomenon, it's called UTOF, is that when patients with MS, if they're exposed to the heat, their all symptoms are going to get worse momentarily or temporarily. And we call those pseudo relapse, and that can happen even if they're having some sort of infection. So no, to my knowledge, there's no research going on evaluating that aspect. Patients might hate you if you ask them to go to a sauna because some of the symptoms are gonna come back
Exacerbated.
momentarily, exacerbate, exactly. But yeah, it's a good question.
Yeah, indeed. I should mention Dr. Diego Paz, a dear colleague of ours in Honduras. He also believes in adjuvant type therapies and natural therapies to help chronic conditions. So, and he has had great experience with that. So, thank you, Dr. Paz. You talked about the smoldering type MS and how challenging that might be for neurologists or for the patient himself, simply because it is already a neurodegenerative component of the disease. Now, on these particular group of patients, if we were to isolate these patients, would the medications that we are currently seeing in the market work on them as well to decrease the symptomatology and disease progression? One that comes to mind is Acrovus, which was not necessarily mentioned, but it is one of those medications that are constantly floating around. Do you guys provide it? Does your doctor prescribe it? What are your thoughts on this?
Yeah, so Ocrevus is the #1 prescribed medicine in the US because it's great at preventing new relapses. And it's the only one approved for primary progressive MS based on the clinical trial. Ocrevus molecule is big. It's a big molecule. It doesn't cross the blood-brain barrier. So it's acting just in the periphery. The field, what we are moving towards is small molecule that penetrate the brain, that penetrate and goes to those smoldering type of lesions and help with that. And there are a few small molecules, tolebrutinib, which is the Bruton tyrosine kinase, is a very small molecule. And that is probably why, by targeting the microglia, why it's helping with this progression. And it's the one that has the best evidence right now. There are a few that, in theory, for example, there are a few of the medicines that, because they are small molecules, sometimes I use it just a very theory expert kind of base, knowing the biology, knowing the pharmacology, that they might help. But no, we don't have any great medicines that target the smoldering MS besides the one I just mentioned.
Very well. Karen, she is wondering, actually, she says, thanks for the informative lecture. Can MS be misdiagnosed? Maybe
20%.
fibromyalgia?
Oh, yeah. Approximately 20% of patients with MS are misdiagnosed. It can be either overdiagnosed or underdiagnosed because we don't have any specific test. We don't have, it's just putting everything together, the MRI, we have put the clinical symptoms, the neuro exam, and then we come up with a syndrome that we are calling MS. But yeah, so 20% of patients are misdiagnosed with MS. And unfortunately, I see that a lot. Second opinion of a patient diagnosed with MS 30 years ago. And I'm not blaming other providers because we are learning about this disease. And I look back, it's like, you don't have MS. It's hard to undiagnose someone. It's a process that takes several visits. But yeah, it can be misdiagnosed with fibromyalgia, with migraine, with other conditions as well. In fact, the new diagnosis of criteria for multiple sclerosis is meant to be a little bit more specific. It's looking at a few of the brain imaging biomarkers like the pearls that are more specific for MS.
Mm.
So this year, hopefully, we'll have new diagnostic criteria, and hopefully the rate of misdiagnosis is going to go down.
Um, Tamas Chess is saying, thanks for the excellent presentation. Do you manage RIS or radiologically isolated syndrome in light of the ongoing photobiological process, smoldering MS, for instance?
Yeah, great question. Yes, I lean towards treating these patients with radiological isolated syndrome. It's a little bit more complex than that because we have to look at first, do we think this is radiological isolated syndrome? Because they can have just white matter disease from something else. And after I say, yeah, this is radiological isolated syndrome, I try to look for risk factors that may indicate that they are at risk of converting to MS and worse prognosis. One of those, if they have spinal cord lesions, if they are male, I do a lumbar puncture, and if I see oligoclonal events, that's an indication. It's like I would like to treat this patient now, because if we follow these patients 10 years, almost half of them are going to develop a clinical attack. It's a waiting game. It's definitely a discussion to have with the patient. I would prefer to be a little bit more aggressive and treat it, even if it's not with a high efficacy therapy, but I would treat those patients at least for a few years. There's been 2 studies looking at these patients with radiological isolated syndrome, and they were both treated, and they were both favor of treating these patients.
So in your experience, obviously, all these treatments that we have mentioned has definitely changed the paradigm then for this group of patients. It has improved somewhat the staging of the condition.
Yeah, for sure. Even now, looking at MS as a spectrum, radiological isolated syndrome, in my eyes, is MS. It's just waiting for to have a first clinical attack, but the biology is there. The microglia, activated microglia, ongoing inflammation is there, like that person was mentioning. Yes, MS is MS.
It is.
Even if it's mild or
However you
very
see it,
severe.
that's it. Now, finally, Doctor, quick question. Do we have currently any clinical trials in MNI for MS?
Yeah, we are working on it. We are in the discussion phase of with different companies, and even one for stem cell therapy. All those are ongoing and in the process.
That's phenomenal. And you did say those that are already bedridden or wheelchair bound are the ones that need our help the most, and those are the ones that we should target. Well said, Doctor. You know what, Dr. Brugal, Compres Brugal, this is such a fascinating subject, and we're just scratching the surface. So I know that moving forward with your expertise and the team at MNI, we'll have more discussions, especially when you open the clinical trials in the future. So I want to thank you for everything that you do for our patients, and not only domestically, but internationally. And on behalf of our entire team at International, thank you once again for your informative presentation. And to all of you for participating and attending today's lecture. If you have any additional questions or you have a concern about a specific patient that you're treating in your respective countries, and you want to ask more about multiple sclerosis, please feel free to email us at BHIWebinars@baptisthealth.net. Again, that is BHIWebinars@baptisthealth.net. We will make sure to forward those to Dr. Compres Brugal for his analysis and expertise and share the results of that with you. We look forward to seeing you all in our next Neuroscience lecture series, which is scheduled for April 23rd, 2025. I want to wish you, on behalf of the entire team at Baptist Health International and our neuroscience department, a phenomenal new year and filled with incredible knowledge and expertise in order for you to continue helping our patients and yours domestically. Thank you very much once again, Doctor. Have a wonderful day. Goodbye, everybody.
Thank you all.